Morning, or at least it's morning in Montreal. It's a great honor to have received the Fukuhara Award. I would like to spend the following 40 minutes to 45 minutes to share with you some thoughts about suicide around the world, and particularly the issue to what extent is suicide a universal phenomena, which is pretty much the same for all human beings, and to what extent there are cultural specificities and differences in suicide and how we prevent it around the world. I'm here at the Université du Québec à Montréal, French-speaking university, currently with no students. Everything's virtual because of the COVID situation. And the time is short. It's really an impossible task to critically summarize best practices in suicide prevention in cultural context in 45 minutes. So what I'm going to try to do is basically plant seeds to try to stimulate some consideration of some of the issues that have been of interest to me over the past years. Most research and intervention on suicide prevention assumes that there are commonalities in suicide worldwide. There is often some recognition that you need to adapt things to culture, but organizations like the International Association for Suicide Prevention and the World Health Organization develop general guidelines. For example, how media should report on suicide, or what constitutes safe messaging, or how to prevent suicides in prisons, or how physicians should interact with someone who's suicidal and assess risk. And there are guidelines for national policies with lists of actions that all countries should undertake. The general assumption is that this is universal, and it's pretty much applies worldwide, and you need some linguistic translation, maybe some minor adaptations to the local culture and the nature of the mental health and health service delivery systems. But basically, this is a universal phenomenon. One can ask, however, is this assumption justified? I'm going to start out by talking generally about suicide and how I understand it. I can't actually read this, but I've seen the translation. This is an early Egyptian hieroglyphic, and it's part of a series of 200 and something tablets that a man wrote. And it's basically called The Man Who Is Tired of Life. And these tablets tell the story of a man who is debating. He's ambivalent. He doesn't know if he should kill himself or not. And if you take out the parts which tell about his voyage in the afterlife, which is specific to the religion of the time, the story could be anyone. He has classic symptoms of depression. He gets up early in the morning and can't go back to sleep. He's ambivalent about suicide. Suicide has existed since the earliest records of mankind. Suicide exists everywhere in the world. There's no culture, place, or group that does not have suicides. If we update this map, some of the colors will change. And this is WHO reports on suicide. And if you ask the general question, why do people commit suicide? I believe that the causes have never changed. You find the same answers in the descriptions for thousands of years. Some factors, risk factors or protective factors, may be more important in different periods of time and cultures. But basically, the answer to this question is people kill themselves to stop suffering. Suffering that they think is interminable, unavoidable, and insupportable. The word think is the important one. So there's a 16-year-old who says, my girlfriend left me. I'm suffering. I can't stand the suffering because she left me. And there's nothing I can do. She's never going to come back. And I'm never going to fall in love again because this is the love of my life. You may think to yourself, that is ridiculous. She's 16. But if that person at that moment is thinking that, he can go ahead and attempt suicide. So there's a perception of the person that things will never end. There's nothing I can do about it. And I just can't go on. It's too much for me to handle. Now, one of the curious phenomena or aspects of suicide, which appears to be universally true, is that the vast majority of people who seriously consider suicide don't go ahead and proceed with a suicide attempt or die by suicide. Suicide is a rare phenomenon that doesn't diminish the fact that it is tragic, and I believe almost always tragic. But there's lots of people each year seriously consider suicide. Probably, if you look at the research, between 2,000 and 4,000 per 100,000, 2 to 4% of people say, I seriously thought of killing myself. If you ask people if they attempted, and some of these attempts are not lethal attempts or dangerous, but many are, about 300 people per 100,000 will report that they attempted each year. And there are some variations from country to country, but it's around that ballpark. But only, if you look on a worldwide average, about 11.4 per 100,000 will die by suicide each year. So most suicides are prevented by the suicidal person. So most people, even people who are so desperate that they go about and begin a suicide attempt, will, for the most part, stop the attempt. They will get help and not go on to die by suicide. So suicide is mostly prevented, and it's tragic when it's not prevented. There's quite a lot of research on suicide. In the last 30 years, there's 41,276 published articles, at least, if you do search for them. And those articles have some interesting characteristics. Most of them, 82.8%, are from high-income countries, mostly English-speaking, mostly from the US, EU, Australia, and Canada. But 80% of all suicides in the world don't occur in those countries. They occur in low and middle-income countries. So most of we know comes from a limited sample of the world cultures. For example, one of the methods of suicide research, psychological autopsy studies, 98% come from 10 countries, 42% the UK, 25% Denmark, 14% Israel, US, and these countries. Between 2010 and 2020, 89.2% of all the publications were about professional psychiatric or biomedical interventions among those studies which talked about how to help people or intervene or prevent suicides. However, 46% of the countries in the world have fewer than one psychiatrist for every 100,000 inhabitants. 22% have fewer than one psychiatrist for every 1,000,000 inhabitants. So most mental health care in the world is not provided by mental health professionals. Family and community play a major role. Just for curiosity, I correlated the number of psychiatrists per 100,000 population and country suicide rates, and there's a worldwide positive correlation, 0.37 for males, 0.29 for females. Basically, the more psychiatrists you have in a country, the more suicides there are. And in Europe, having more psychiatrists is associated with having more female suicides and not males. Of course, this is correlational data and not causal. The suicide rates have been going down in the world. That's a good thing. 2000 to 2016, they went down about 18.5%, but not everywhere. For example, the rates have been going up and are still going up every year in the United States. But what's curious is the countries with the most decreases are the countries with fewer psychiatrists, where all the treatments that have been shown to be effective in the research are not that easily available. And they've been going down, particularly among women in these countries. And one can ask why this is. Has something changed in terms of women's status, access to help, or opportunities in middle and lower income countries? Why is it that 89% of suicide research reports on biomedical treatments and approaches? Well, one reason is that drug companies finance research. About 20% of all published research is financed by drug companies. And what do those researchers research? They research drugs. And also, most researchers are psychiatrists who prescribe drugs and psychologists who evaluate people and treat people with psychotherapies. And a lot of the people work in hospitals. Community organizations don't have money to do research, so there's a lot less research. They don't initiate a lot of research, and it's not as well funded. For example, telephone helplines, which exists in most of the countries in the world. Now, internet, chat, and text messaging help is available. It's about 1.2% of published research. Gatekeeper training, very, very important item, high on the list of World Health Organization's to-do list for countries who are doing suicide prevention. About 0.6% of research publications. So what we know about suicide prevention is based upon what has been tested in a few wealthy countries with relatively extensive mental health services, which focus on medications because they're well funded, professional psychotherapy, and treatment in specialized psychiatric units. The other thing about research is we only publish on people who are good participants. They participate well in the research. The people who we have tested treatments and prevention activities on are people who agree to try the intervention. So they'll do the CBT therapy or they'll take the drug. They're willing to participate in a research study as well. So we don't know anything about people who refuse or don't like to participate in research. And they all adhere strictly to the treatment protocol. So if it calls for 3 months of psychotherapy, they include everyone who made it through the 3 months, did their 3 months of psychotherapy, or took the dosage of drugs they found in their blood to be consistent over a period of months or weeks. But in reality, a lot of people refuse things. You say, okay, we'll go to psychotherapy. They refuse. Or they stop the treatment, or they don't take the drugs as they're supposed to, or they don't show up for their appointments. That's a typical situation. So in reality, we don't know anything about what most people do to get help or how they accept the treatments. We just know in an ideal situation what the people who are able and willing to participate and have access to treatments actually do. And then we have different research methodologies, and when we do drug studies, it's usually a randomized controlled trial where there's a control group who gets a placebo or an older medication, and then there's another group that randomly is assigned to the treatment drug, and they don't know about it, and it's very well controlled. And when people do reviews of what seems to work, you look at the quality of the research, and the RCTs, they're the gold standard. But control groups are controversial in suicide research. It's not considered ethically acceptable to give a treatment to half the people and not treat the others or give them placebo or play therapy or something to occupy their time, and then count how many people die in both groups. When you have someone who's thinking of suicide, you can't just stand by and say, tough, you're in the control group, we'll see if you die or not. So it's harder to do those studies on community interventions. We can't, have some of the people have a publicity campaign and the others not, if we think this is helpful. So we don't know a lot about certain types of treatments. And when we do meta-analyses to summarize research, they say what works is what we have quality studies telling us are effective, and there's not enough research in a lot of areas, and people write this up. But just the fact of having published more research on something doesn't mean it's more effective. Most of the research we have it concerns risk factors. We know very well how to make someone suicidal. We have very little research on protective factors. We can list hundreds of things that will increase the risk that someone will die by suicide, but people rarely have studied individuals who have risk factors, but are able to cope with the situation. They don't think of suicide. They don't attempt suicide. There's very little on resilience. So maybe we have to step back and reassess how to achieve zero suicides. I use the term zero suicides because there's a worldwide movement now called Zero Suicides, which says that we can reduce suicide worldwide if we all do all these things that have been proven in research. So I'd like to consider for a little bit what we would have to do to have a world without suicide, or with a lot fewer suicides. And I'd like to at least list a few things to change if we really want to have an impact on suicide worldwide. The first is we need to come up with things to prevent suicide in countries with few mental health professionals, which is most of the suicides in the world and most of the people in the world. I've done some training in Uganda. It's a few years back, but at that time they had 18 psychiatrists and 30 million inhabitants, and most of the psychiatrists were professors or hospital directors, so the chances of seeing a psychiatrist are much lower than one in a million. And one of the major challenges is the stigma and societal beliefs about suicide. In Uganda, for example, even though almost everyone is Christian, there's a small Muslim population as well, and people have a high percentage of population going to church on Sundays. They still have a lot of traditional beliefs. When I gave a training session, there's a minister, an Anglican minister, who happened to be in the session, which was for mental health nurses, which do exist and prescribe medication, do everything that psychiatrists and psychologists have to do elsewhere. And they said a little prayer, please help us learn and be able to help people and protect us from the spirits of people who died by suicide, who might come and haunt us because we're talking about them. Amen. And in Uganda, it's not unusual for someone when they've died by suicide, to have the rest of the family shunned. No one will marry them. Or if someone is found hanging on a tree, they would just dig a hole under where they're hanging, cut the rope, throw some dirt over it, and have the family buy the land. In some villages, they burn the house to the ground with the dead body in it when someone's died in it. And others, they cut a hole in the wall and take the body out from the side door. And at funerals for persons who die by suicide, it's not unusual to beat the body during the funeral to punish it in front of the family, and throw the body into a pit outside of the graveyard. So a challenging stigma and various beliefs makes it is an important issue. Another issue which is crucial is to look at what makes people accept treatment, what makes people more open to seeking help and continuing treatments, because when people do research on what works, you get it perfect. You have this setting where you keep getting people to come and do everything, and they're fine, and you prove it works. But the biggest challenges aren't finding out what works. It's to find out what works that's acceptable, that people will go to, and the treatments are going to continue within specific cultural context where there's people are reluctant to seek help or consult a mental health professional for various concerns of being thought of as crazy or being hospitalized. We need to know a lot more about this. You can't talk about suicide prevention without talking about social inequities. You know, it's one thing to, you know, talk about suicide prevention where people have enough to eat and they're clothed and life is relatively easy. But we have research which clearly shows that deprivation, material deprivation, interpersonal, social, and cultural deprivation is associated with increased suicide vulnerability. This is a map of northern Canada, the territories which have mostly Inuit populations. And I have a project going now in Nunavut. The North Pole is about here. The Arctic Circle goes around like this, just about. And in these communities, there's an idea of an isolated community. There's no roads to go from one place to another. They're spread out. You know, Nunavut alone is the size of all of Europe, and it's got about 40,000 inhabitants scattered. But you look at Inuit throughout Canada, and you find that 39% are in crowded houses, compared to 4% of all Canadians. And often it's 10, 20 people in a 2-3 bedroom home. 29% of Inuit aged 25 to 64 have a high school diploma compared to 85% of the general population. And when you compare how many have food insecurity, it's as high as 70%, where children are going to school without breakfast. And it's it's an expensive place to live. All food, except for what you hunt, has to be flown in. And the median income on Inuit is less than $18,000 Canadian. And non-Indigenous people who are living in the same territory, their median income is $78,000, which is, you know, what people think they need to live there. And there's many fewer physicians, unemployment rates are higher, and life expectancy is lower. And, you know, when you're, these are all stresses which add to our understanding of the context in which we're trying to help people. And it's not surprising that the suicide rate for that and a lot of other reasons, including transgenerational trauma. So the red line down here is suicide rates in Canada, around 12 per 100,000, and in the rates can go as high as 20, 30 times higher and up to 40 times higher among Inuit youth. When we plan to do something, we have this great idea. We're going to come in and we're going to do it. It's all going to turn out just fine. The reality is often not quite as easy and direct as we have planned. Currently, there is an emphasis on implementation research, or sometimes called implementation science. And implementation research is concerned with not the effects of programs. Did it prevent suicide or not? And it's not concerned with, can we control things and get enough people to do the protocol to get some positive results? But it deals with issues like uptake. What makes for someone to actually use a treatment or seek treatment? How can programs be used in an effective way and in an equitable way, where it's reaching the people and helping the people who actually have the most needs? And so it looks at context, how contextual factors influence the development, the implementation, the use of programs, how they're perceived, ranging from political factors to cultural and beliefs and existing services and structures, and practical things like in rural areas, transportation issues to get to mental health services. Another point has to do with technologies. As they say, the anthropologists are coming and they're hiding all the tech gear. We have this idea that when we talk about other cultures, we're talking about getting rid of all this sophisticated high-tech stuff. More business transactions in small enterprises, such as family farms, are conducted per capita in Africa over intelligent phones, iPhones, Android, and whatever, than in high-income developed countries. 2013 was an interesting year of change. It's the year when more people on Earth had a paid subscription to a cellular service, portable phone service, than there were inhabitants on Earth. There are more paid subscriptions since 2013 than there were people living on Earth. So that means that counts babies. So a lot of people have more than one paid subscription on average. So we can't avoid new technologies. And I think people in suicide prevention have been late in adopting what's trending in new technologies and adapting to them. We need to be aware also that these technologies pose risks. And I can't go into much detail in this short talk, but one of the risks which concerns me particularly is the openness to inequities. Right now we're using algorithms, and there's research showing that a computer algorithm is better at deciding what the suicide risk of a person is than a clinical assessment by a mental health professional. And when we use an algorithm to determine who's at risk of suicide, people think this could be helpful. For example, if we have limited resources available, it would be better to, people feel, to use those resources for the people who are most at risk rather than waste them, in quotes, on people who are not so much at risk. So you create an algorithm, for example, in your wait room to have help over the internet in a chat situation by a suicide prevention center. You ask a bunch of questions, and an algorithm will determine who's most at risk. Well, the algorithm can continually improve themselves, and they're really good at it. They'll get at the people who are most at risk. And if we use this, we'll help maybe a few more people, but there's a possibility of bias. For example, men are 4 to 5 times most at risk of suicide in most countries, in a little different in Asia, where it's closer to equal in China, India, but in countries where that's the case, that's clear. So if you want to help more people, you're going to help 4 to 5 times as many men than women, and you're going to help more people. Is this fair? Is this equitable? Are people who are less at risk but still at risk, should we exclude them in order to, as the CDC once said, get more bang for the buck by helping more people for each dollar invested? So I think this is the sorts of things we need to be aware of. Now, Freud had a notion which people accepted for a while, and that is that people have some aggressive tendencies, and that these tendencies could be expressed either externally with violence towards others, or they could be turned inward and become suicidal and violence towards oneself. And he that it was one or the other. If you expressed your violence externally, you wouldn't express it to yourself, or vice versa. Well, basically, he was wrong. All the research indicates that violence breeds violence, including suicides. The more violence there is in a society, the more suicide there is, and violence includes exposure to violence in films, on the internet, and other media. And we are constantly exposed to things from subtle bullying to horrific violent acts. And even young children are exposed to this through media. And you'd be surprised at the violence in children's cartoons and things like that. So basically, more violence is related to more suicides. And this may be one of the key explanations of why, despite massive investments in the United States in suicide prevention and very good programs, suicide rates are continuing to increase, because despite that massive investment and they're saving lives and being more available, there's a lot of violence and there's easier access to guns. So one way to prevent suicides is to reduce violence in general within a culture. I've already mentioned that almost all the research is about risk factors. We need to focus more on increasing protective factors instead of understanding why people die by suicide. Most research focuses on that. We need to understand how people, despite their adversities, go on and get help. And where suicide rates in women are going down, maybe we want to look at things like improvements in opportunities for women, or HIV/AIDS is a high-risk group. People who have this, rates have been going down. It may be associated with better services for this high-risk group. One other protective factors might be a positive involvement by religious leaders. Muslim culture has been Muslim religion condemns suicide. It's haram, it's a horrendous sin, it's something you shouldn't be doing. So what are the implications of this? In some countries, including Iran, which has active suicide prevention services, one reaction to this is to say, it's not right to kill yourself. We're going to do everything we can to protect people from doing things that are not acceptable according to our values, according to our religion. So we're going to invest in suicide prevention and mental health, understanding that a large number of people who die by suicide have mental health problems. And other countries, same religion, say we're going to punish people by not sending an ambulance if they attempt suicide, or in over 20 countries, I have statutes with prison sentences for people attempting suicide. And there are people around the world who are in prison for attempting suicide, though some countries, the latest was Singapore, which finally decriminalized suicides. And another thing, which is to improve coping skills and resilience. Now, I've already stated that I view suicide as a way of coping with a problem which we think we can't cope with, we can't deal with, it's going to go on forever, we're hopeless and powerless in this. And there are programs to improve coping skills. There's research showing, for example, adolescents who attempt suicide can think of fewer ways of coping with problems compared to adolescents in similar situations who don't attempt suicide. And I've been involved in developing and evaluating 2 programs to teach young children coping skills: Zippy's Friends for 6 and 7-year-olds, Passport Skills for Life for 7 to 11-year-olds. Zippy's Friends has been used in 30 countries, 1.6 million children around the world, and they both don't tell children how to cope, but teach children to evaluate, are these coping things helping me feel better or improve the situation, and teaching children to try to think of different ways to cope with problems. I don't have time to go into the details. These are some things from Passport Skills for Life, which uses comics to have different stories and talks about understanding emotions in games. And it has proven, as Zippy's Friends has, and Zippy's Friends has been around for longer, it's been over a dozen really good controlled studies, it improves coping skills at a young age, and you want to start as soon as possible. The last point is that has to do with how we go about dealing with people who are at risk of suicide. And I do training in different countries, and and often I do training in places where people are working with people in desperate situations. And when I start the training sessions, it always occurs that someone interrupts me and says, yes, but how can I prevent suicides? I'm working in a refugee camps, and I have these Somali refugees who are stuck in Tanzania, and they're never going to go home, and they witness their family tortured to death in front of their eyes, and they're all alone in this strange place. And how can I possibly say anything or do anything to prevent them from killing themselves? I'd feel the same if I were them. And the answer to that is simply, they're still alive. Something is keeping them alive. And your role in suicide prevention is to understand what are the things that have kept this person alive to still be talking to you today after and despite going through those circumstances. So instead of asking the person to tell about these horrendous situations, which are real and important, and some people do need to talk about them, and to focus on undoing things which cannot be undone, you need to focus on the person's strengths. Now, every research study to date has shown that lay volunteers are better than professionals in helping people who are suicidal. Every single one of them. One exception where they were both equal, and that's a study I did, and explain that another time. But basically, professionals focus on problems and dealing with problems, talking about problems. Help comes from building hope by focusing on strengths and believing in abilities to want to continue living despite the problems. Now, I'm running out of time. If I had more time, these are some pictures of some refugee children and Somali refugees in a camp in Tanzania, and who are not happy. And I could talk a little bit more, and could talk a little bit more about how you build hope by focusing on changing the person's perceptions, focusing on those moments when things were a little better or not so bad even. What helps people continue to live, exceptions or glimmers of hope, and what has helped them when they've thought about suicide. And there's you can do a whole workshop for hours on building hope with various techniques. I'm going to end here. I think that it is important to also look at things that are not being written up in the scientific journals. For example, New York Times reported on a man who heard there were a lot of suicides on a bridge, so he went to the bridge and greeted people walking across the bridge and said they was available to talk with anyone that had any concerns. And there didn't seem to be any more suicides on that bridge since he started just doing this. In a Canadian community in northern Canada with Indigenous people, there's high suicide rates among people who are awaiting trial. And in fact, there are more suicides in the world of people waiting trial than people who've actually had their sentence and gone to jail to serve for their crimes. And one of the community leaders decided, I'm going to just go in the cell with people who are waiting trial and stay with them for a month or whatever it takes until their trial, and just keep them company and talk with them. And there's been no suicides in anyone whose cells he's shared. And actually, there's been very little repeated crime from those people who had an elder of the community spending weeks living in the cell with them and being available to talk with them. In Sri Lanka, Samitrio, a volunteer helpline organization, sent people into communities where there are poor rural communities where there are high suicide rates with women. And what they did is they organized women's cooperatives they brought scraps of clothing that were being thrown out, and they sewed them together to make these colorful clothes. They brought it in, brought the money in, but more important, the women worked together and talked and shared as a community, doing something as a profit. These are examples, there's lots and lots of them, of things that have never been scientifically evaluated or written up, or you'll find in the WHO guidelines, because there's no research on it. I think we can learn a lot from different communities, but I think we need to shift our focus. Thank you very much, and there'll be some time for some questions and reactions.